Welcome back to the Deep Dive. Today we are taking a really fascinating and rigorous journey into the world of diagnostic imaging.
We are.
You shared a highly specialized clinical review. I mean, this is the kind of document written for absolute experts, all about identifying the subtle, often overlooked signs of breast cancer in mammograms.
That's right. And the source material, it's not just a guide, it's more like a detailed operational checklist. It's designed to minimize failures.
So what's our mission here?
Our mission in this deep dive is to pull out those key diagnostic concepts, to give you a shortcut, really, to understanding the level of meticulousness that's required. We're learning the expert shortcuts to reduce the chance of a missed cancer.
And the stakes couldn't be higher, which is why this focus on subtlety is so crucial. The source material hits you immediately with this striking, pretty sobering statistic.
It really does.
Mammography is the undisputed standard of care, but it isn't perfect. And get this, approximately 10 to 30% of breast cancers can be missed during a routine screening.
10 to 30%. That's a wide, but wow, a significant margin for error. And the paper doesn't just list the problem. It breaks down exactly why those misses happen.
Into what categories?
It's sort of three core factors. First, you have anatomical issues, dense breast tissue that physically hides a finding.
Okay.
Second is technical errors, like suboptimal positioning. And then finally, perception or interpretation errors. The finding was there, it was visible, but the eye just missed it or the brain dismissed it.
So let's unpack how the experts fight back against those three causes of failure. The source lays out a really clear three-part roadmap to enhance accuracy.
It does. They boil it down to three core concepts, and that's going to structure our conversation today.
What are they?
First, pay meticulous attention to technique and positioning. Second, develop a standard systematic search pattern, to eliminate blind spots.
And third,
always compare the current exam to multiple prior studies if you have them.
quality, coverage, and context.
Those are our three pillars. And they're sequential, right? Because you can't get the diagnosis right if the foundation itself is flawed.
So we have to start with quality.
We have to, because as the source says, a cancer can't be detected if the tissue containing it isn't even on the mammogram in the first place. Suboptimal positioning is, believe it or not, one of the biggest factors.
This is the essential prerequisite then, the technical barrier to entry. For you, the learner, this isn't just about general discomfort or something. It's a very precise quality control checklist.
Exactly.
So what are the signs of a truly well-positioned mammogram?
The source is very specific here. It lists 5 non-negotiable signs that confirm you've included the maximum amount of tissue.
Okay.
Some are pretty basic, like making sure the nipple is in profile,
Right.
and that the inframammary fold, the crease underneath the breast, is open and clearly visible. But the most critical checks are all about the tissue depth.
Okay, this is where it gets really technical and interesting. How do they measure that depth and guarantee you've gotten all that posterior tissue?
They use something called the posterior nipple line, or PNL.
PNL.
It's a crucial anatomical landmark. On the MLO view, that's the one taken at an angle.
The mediolateral oblique.
Correct. On that view, the PNL has to extend all the way to the pectoralis muscle. If you don't see that muscle, you know you're missing deep tissue.
But the real quality check comes when they compare that measurement to the other view, right? The top-down.
The CC view, the craniocaudal, yes, that's the key.
So they're measuring the depth on 2 different angles. What's the rule for that comparison?
1 centimeter.
That's it, 1 centimeter.
1 centimeter. The difference in the PNL measurement between the CC view and the MLO view must be less than or equal to 1 centimeter.
And if it's more?
If it's more, it means that top-down shot, the CC view, didn't get enough of the posterior tissue. Findings could be hiding right there, near the chest wall. It's essentially a mathematical check on the image quality.
So that 1 centimeter margin is the boundary for error. It's like if the picture from the top doesn't match the one from the side within that tiny window, you know you've missed something.
Absolutely. If those criteria aren't met, the study is technically inadequate. It should be repeated. You can't start the diagnostic clock if you haven't captured the whole field.
Now, beyond poor positioning, the sources also highlight another huge technical pitfall: motion artifact.
Oh, motion artifact is It's the definition of a technical hurdle. It happens from involuntary patient movement or sometimes just compression that isn't quite optimal.
And it's more common in certain views.
Yes, especially in those detailed spot magnification views. The exposure time is longer, so there's more chance for movement. For the patient, this is just frustrating because the image is essentially nullified right away.
And what are the consequences for detection if that motion artifact is there?
They're disastrous. First, it literally blurs critical features. Think about tiny microcalcifications. Their sharp edges are what matter, and motion just blurs them out.
A technical miss?
A total technical miss. And worse, it can create a pseudomass, a completely false appearance of a lump.
Wow.
Or, on the lip side, it can hide a real mass, making it blend right into the surrounding tissue. So if motion is suspected, you have to repeat. Quality first. Always.
Okay, so let's say the technical quality is perfect. We've got all the tissue, no motion. We've removed that first barrier. But a perfect image still needs a perfect viewing.
Exactly. And that brings us to our second pillar, coverage. Specifically, avoiding those blind spots.
This is where we shift from, what, physics to psychology?
Pretty much. This section is all about interpretation errors, especially a pitfall they call satisfaction of search misses.
Tell us more about that. How does the human brain get in the way here?
Satisfaction of search. It means the radiologist finds one abnormality. Maybe it's a simple cyst, something benign.
Right.
And their brain just registers problem solved. And then they stop searching as thoroughly. They think they've found everything, and they miss a separate, often more subtle, malignant finding hiding somewhere else. It's a cognitive trap.
And the counter to that trap is a standardized search pattern, forcing yourself to look in all the hidden corners.
A rigorous one, yeah. The sources identify 7 specific zones where cancers are hard to see and often get overlooked.
The deep search checklist.
That's what we'll call it. It means methodically checking the perimeter areas, like the axilla, the skin, the nipple areolar complex. But the really dangerous internal corners are the retroglandular fat and the lower and inner triangles.
Let's focus on those boundaries first. With a dense breast, the normal edge of the tissue should be sort of smooth, right? Convex.
It should be. And the source flags one really specific subtle sign at that crucial anterior fat glandular interface.
And what's that?
This is where the language gets surprisingly evocative. One of the key subtle signs of cancer, specifically invasive ductal carcinoma, is architectural distortion right at that boundary.
How is it described?
Visually, it's described as looking like the pulling action of a crochet hook.
A crochet hook. That is a powerful visual.
It is. That small pulling distortion, that little dimple in the contour, even if it's only with some minor asymmetry, it demands immediate attention.
Why is visual metaphor like that so important?
It's everything. It gives the brain something concrete to latch onto, not just a subtle asymmetry. That description, the pulling action, tells you the cancer is physically tethering the tissue, pulling everything inward.
And the case examples in the source show this leads to a diagnosis.
They confirm it. Finding that subtle visual change, that crochet hook distortion, often leads straight to a diagnosis of IDC.
And what about those deep hidden spaces you mentioned? The retroglandular fat, the lower and inner triangles. Why are those such red flags?
It's all about basic anatomy. Those areas deep in the breast near the chest wall, they should normally contain only muscle and fat.
Okay.
They're not supposed to have any glandular dense tissue, so any density you see there, any mass in the retroglandular fat or those triangles should immediately raise significant concern. Cancer is finding a path of least resistance into a space that should be clean.
We should also loop back to the axilla. The source points out its importance, especially if the main finding is more central in the breast.
Right. This is all about lymphatic drainage patterns. The source emphasizes the role of the sappy plexus.
The sappy plexus.
It's a rich lymphatic network right under the nipple and areola, and it drains straight to the axilla. So if you find anything suspicious in that retroareolar area, it's mandatory to do a meticulous axillary node assessment. You have to follow the plumbing.
Following the plumbing. That brings us right to the third and maybe the most powerful pillar of accuracy: context.
The power of comparison. Looking at the current images right next to every prior study you can get your hands on.
And this is vital because it shifts the entire question, doesn't it?
It completely shifts it. You move from, does this lesion look bad right now, to the much more important question, has this tissue changed over time? That historical context is everything for subtle findings and for monitoring patients who've had surgery.
The source breaks down 3 main types of asymmetry, but it stresses that the context, especially the risk percentage, Is everything. Let's start with the most common one.
Okay, the most common is focal asymmetry. This is tissue you see on two different views, but it doesn't have the round borders of a mass. It might have fat mixed in.
And it's common.
Incredibly common. 87% of screening populations. And here's the vital number. It has a very low likelihood of malignancy, only 0.67%.
0.67. That number is a huge insight. It tells the expert where they don't need to panic.
Exactly. It lets them reserve their mental energy for the real red flags.
Okay, what about global asymmetry?
Global asymmetry is where you have asymmetric tissue across more than one quadrant. Again, seen on two views, but it's not a defined mass. It's often just a normal variant.
And the risk?
If the patient is asymptomatic, the malignancy risk is effectively 0%.
Zero.
Zero. Now, if that area is palpable, the risk only jumps to about 7.5%. Again, context is key.
But the real red flag, the one that demands immediate, meticulous attention, is the third type, developing asymmetry.
That is the critical finding. Developing asymmetry is defined as an asymmetry that is new, larger, or denser than it was on any prior exam. That change in context completely alters the whole pathway. If it's developing, it is highly suspicious.
This idea of comparison is also crucial for evaluating the post-treatment breast, right? After a lumpectomy and radiation.
Yes, because it can be incredibly difficult to tell a normal healing scar from a local tumor recurrence.
So how do you tell them apart?
The timeline is the key diagnostic tool here. Post-lumpectomy changes usually evolve for about 2 to 3 years, and then they should stabilize. A normal, benign scar will be stable over time.
What does it look like?
It often has little radiolucent, fatty areas mixed in, and if there are spicules, those lines radiating out, they tend to be thick and curved.
Okay, so a stable scar, some fat, thick, curved spicules. But if they see a change after that 2 or 3 year stability window, what suggests recurrence?
A recurrence often shows up as a new central mass, right at the surgical site. And the crucial difference is the lack of those normal fatty areas. The recurrence tends to obliterate the fat.
And the spicules.
Instead of thick and curved, you typically see fine, straight spicules radiating out from the new mass. The subtlety is all in the geometry and the timeline.
It's all pattern recognition. Why would the type of spicule be such a distinct clue?
Yeah.
Fine and straight versus thick and curved.
Well, the benign scar with its thick, curved spicules, that represents fibrosis. It's the body healing pulling tissue inward, but with a degree of softness.
And the malignant ones.
The malignant spicules, the fine, straight ones, that represents an invasive process. The tumor cells are aggressively infiltrating tissue in straight lines. It's the difference between healing and active invasion.
Finally, we have to circle back to the lymph nodes, especially for patients who've had breast conservation surgery.
Yes, the source really stresses that the axilla must be carefully evaluated for recurrence.
And this raises a really important point. What if a lymph node isn't enlarged, but it's changing in other ways?
This is a profound teaching point from the source. Management should be determined by the most suspicious feature, even if the node is a normal size. The internal architecture matters more than the diameter.
So what are those key internal changes that flag a problem, even in a small node?
Things like focal cortical thickening. One specific area of the outer shell gets thicker. Or calcifications, cortical irregularity, or, and this is the most telling one, loss of the normal fatty hilum.
The fatty hilum.
It's the center of the node. It should be bright and fatty on the image. A small node that's lost its fatty center and has some cortical thickening that still needs immediate evaluation. It just underscores that vigilance for change is the ultimate key.
That attention to change, regardless of size, really defines this entire deep dive. So to synthesize for you, the learner, it all rests on these 3 unshakable pillars.
Quality, perfect positioning to capture everything. Coverage, systematically searching those hidden zones. And context, using prior exams to spot developing change.
The ultimate takeaway really is vigilance for that change.
It is. The source specifically highlights that even a unilaterally enlarging lymph node on an otherwise normal mammogram requires immediate attention. Subtlety is so often defined not by how something looks right now, but how it's evolved over time.
And as we close, let's leave you with this provocative thought. It's based on a subtle operational detail the source mentions.
Oh, this is a great one.
It says that missed cancers can be minimized simply by altering the viewing procedure, forcing the expert to review the images side by side as mirror images.
So the top-down CC views together, the angled MLO views together.
Exactly. And that procedural mandate, forcing a systematic, mirrored comparison against a baseline, is such a fascinating idea. It bypasses the brain's tendency to just look at things one after the other and miss small differences.
It really does. And you have to wonder what other fields, completely outside of medicine, could reduce their error rates just by forcing that kind of comparison.
A strictly mandated, mirrored comparison protocol.
Exactly. Instead of just sequential viewing, it's a powerful idea.
Think about that for a minute. Thank you for diving deep with us. We'll see you next time.